Excellent. Alrighty, for all those gathered here and all those that will be listening to me online, I'm Dr. Mark Strazisar. I'm a board-certified psychiatrist practicing at Mill Creek Community Hospital. I've been doing psychiatry for about 12 3/4 years. It might be more like 5/6. I'm not really counting. But this is one of the topics that truthfully is one of the hardest ones to give about self-injury. And the reason why it's so hard is we don't like to talk about it. It's unsightly. It's scary. I'll make it worse. But something has to be acknowledged, has to be addressed, because it can head off something that is far, far worse. So the objectives of today's lecture is to identify what is self-injury, recognize the signs of self-injury as well as causes for self-injury, and utilize resources to help treat self-injury and prevent its furtherance. Now, March 1st, it's a doubly important day for me. One, it's my eldest daughter's birthday, and I always celebrate that. And then I found it was also Self-Injury Awareness Day. It took on a little extra meaning, especially because about 4 years ago, she came to me and actually asked some questions about this. This was rather unusual. She was only 11 at the time, and I was kind of curious as to why she was asking that. It's because some of her friends had started to kind of scratch themselves and hurt themselves. She did not understand why anyone would do such a thing. So I felt, okay, this is definitely a topic I want to pursue more and one I want to get out there. Because if someone's asking about it when they're 11 years old, imagine when they're 15 and don't know anything, 19 and don't know anything, 25 and don't know anything. That's scary. So self-injury, it's a pattern of behavior that it causes a person to say, you know what, it's okay to hurt myself. Normally, we are very averse to pain. In truth, pain is more of a reminder of, yes, we're alive, but it's also scary because most of us do not like to be in pain. For example, anyone here ever step on a Lego? Yeah, that's what I usually rate my pain scale as. 0 is no pain and 10's a Lego, because 10 is always the Lego. No one wants to get to that 10, and yet people who self-injure cut themselves, burn themselves, do all sorts of damaging things to their flesh, their sinew, without that natural, ow, this hurts response. So self-injury, we really need to distinguish because there's two types. We have non-suicidal self-injury, which is NSSI. This we find most often in patients with what are called the personality disorders, such as borderline personality. It's also found in some psychotic disorders. You will find it on occasion in schizophrenia and severe major depression. You will find this as well. There's a second form of non-suicidal self-injury called self-injurious behaviors. We see that in more autism spectrum. More they bang their heads, they strike themselves, they cause bruises to themselves. It's a little different because NSSI has a distinct purpose. SIBs don't seem to have a set purpose, and yet they're categorized the same because the treatment is often identical. Now, certainly self-injury can also occur when a patient wishes to complete suicide. So, self-injury populations, it's really common among adolescents and young adults with lifetime rates approaching 15%. That's pretty high. That means about 1 out of every 7 may have this. The onset occurs around 13 years old, and the rates are similar across different countries, both what we consider the first developing world, the classic second world, and even third world. This is rather ubiquitous. It's seen everywhere. Certainly it is highest among the psychiatric populations because these people who are self-injuring, they have negative emotionality. They are very flat, very blunted, very down. They're very depressed. On the flip side, though, they can also be extremely anxious, extremely on edge, no way to stop it. And they can vacillate between that depression and anxiety through emotional dysregulation. Now, the rates of self-injury, now that's nearly equal between men and women. The difference, though, is how they do it. Women are much more likely to cut. Men are much more likely to cause bruising, hitting, or burning. Now, the statistics of non-suicidal self-injury, about a 7.3% prevalence over a year, but that's an 18% lifetime prevalence. So that's pretty high, and that's pretty scary. And again, a nearly equal male to female ratio. We don't have much in psychiatry that is equal. We usually see something more in men than women or something more in women than men. This is a great equalizer. So why do people do this? We established we don't like pain. We don't like that Lego on the foot. Why are we doing this? Well, part of it is to alleviate that negative emotion. At least now I can feel something. And other times I deserve to suffer. I deserve what is coming, and that's a physical reminder of that self-loathing, that hatred for oneself. And on occasion, it is manipulation. But manipulation usually means they aren't actually self-injuring. They're threatening to self-injure. They may not actually be doing it. So often we can start really anywhere on this nice big circle. But emotional suffering happens first, and then there's an emotional overload. What do? I feel too much. I panic. Gotta do something. Okay, when I do this, when I, for example, cut, I get this temporary relief. I feel something, I feel I can calm. I look down at my arm, and I start feeling shame and grief, which leads to more emotional suffering, which leads to more emotional overload. Non-suicidal self-injury can be a form of addiction, an emotional addiction. So that alleviation of the negative emotions, that's the most commonly reported cause. They have these intense negative emotions, and performing the non-suicidal self-injury reduces those emotions. They have this sense of calm and relief. Interestingly enough, this may stave off their desire to cause further permanent harm, such as suicide. So perhaps I'm cutting because I don't really want to end everything, but I need to do something. This is too much pain for me to handle. And again, to demonstrate self-loathing or need for punishment, about 50%. I did very poorly. I did poorly on that test. I failed my job interview. I failed my job evaluations. My marriage is going down the tubes, but I deserve this. I've done something to deserve this. And as an outward example of that, they may cut, or they may injure because this is punishment. This way, I am in charge of my punishment. I am my own judge, jury, and executioner. Now, to manipulate to achieve a goal. This one is the one that a lot of people think is the main reason for non-suicidal self-injury. They're doing it for attention. Look what I can do. I cut myself. No. When you actually self-injure, there is purpose. When you threaten, well, that's more manipulation. Maybe 5% of the manipulation is true self-injury. The rest of it is self-loathing and hatred, or relieving the negative emotions. Now, what causes one to say, I'm going to jump over my pain threshold here and do this to myself? Well, there's got to be something that happened emotionally or traumatically in one's past. Often, it's a history of childhood abuse or neglect. When we have a safe and stable family setting, doesn't matter if it's 2 moms, 2 dads, 1 dad, 1 mom, both parents are in the picture. When there's stability, when there's acceptance of one's self, and pretty much you're allowed to be yourself and allowed to be wrong, you don't see this much. You really don't. But when you are punished for this, when mom unfortunately has a new boyfriend every week and each boyfriend is more abusive than the last, that can lead to the borderline personality, that absolute shattering of one's sense of self. So patients with that history of emotional difficulty or coping with emotions are at a higher risk for utilizing that non-suicidal self-injury as a coping mechanism. Now, before I said, people may try to harm themselves because they don't want to kill themselves. Problem is, as of any addiction, sometimes you start chasing the dragon, as they say. You need more and more and more. Anyone here a fan of MASH? I'm the Alan Alda show. Yes. The name of the theme song is Suicide is Painless. Now, here we're dealing with somebody who does not need, does not have that same kind of a pain threshold. They keep hurting themselves and their pain threshold is rising. At some point, it won't be enough, and they need to take a further step. Instead of cutting into the skin, may cut into the muscle, may cut into the blood vessels. They may decide, this isn't enough, so I'm going to overdose on pills. There may be a very strong prognostic factor that if you self-injure, you may actually be at higher risk for suicide. Normally, past behaviors dictate future ones. If a kid, plays hooky from school 3 days, he's probably going to continue to do so. If somebody is in an abusive relationship, the abuser rarely actually changes. Just like this, previous suicide attempts often predict future suicide attempts, but that non-suicidal self-injury, that can just absolutely take hold. And they may be successful in their first attempt as opposed to what we call classic suicide attempts where they're half-hearted, they try to abort them. So that's why you need to be able to recognize this, because truthfully, and this is going to sound gauche, there's only one way to prevent suicide, and that's homicide. Obviously, we are not advocating for anyone to be killed, but we have to find ways to mitigate the risks, and non-suicidal self-injury is a good mitigating area, something that we can target and perhaps head off that suicide. Now, the interpersonal theory of suicide, we've really touched on this. That Thomas Joyner, he says, people must possess the desire for suicide and the capability to act on this desire. As I said, people tend to avoid pain and discomfort. Non-suicidal self-injury, it alleviates discomfort, overcomes pain. It's a tangible act. I can physically see it. I can physically feel it. It's not just some sort of abstract. It's there, it's present, and it's growing. So looking through this nice little busy slide, there are some genetic biological factors that can lead to a psychiatric disorder, but there's also negative life events that can lead to a psychiatric disorder. You can have a personality that's more aggressive, more impulsive. Or you can have somebody the opposite. They're perfectionistic and they have very low optimism. They have that psychological distress, which can lead down to suicidalization or pain alleviation. At some point, they get exposed to suicide or self-harm. And then they have that availability of method. When it's negative life events or social problems, that tends to be the non-suicidal self-injury that's unlikely to be lethal in and of itself. Genetically speaking, though, there's higher risk. Schizophrenia, after all. Schizophrenics often believe that the only way out is to either kill themselves to deal with the voices, the delusions, or they inadvertently harm themselves escaping said delusions. Nevertheless, non-suicidal self-injury is something that everyone needs to be aware of. Everyone needs to get that basic understanding of the why behind it. However, why is good, but why is it abstract? Where's the physical, tangible proof? Well, it's how it presents. It's not always obvious and is most commonly performed in private. They do it away from prying eyes. They have that guilt feeling, usually hidden under shirt sleeves, pants, makeup, maybe lacerations, excoriations, burns, bite marks. They aren't wearing these scars proudly. Those that do probably are looking more towards the doing it for attention. Those that have older